Hi guys, so I thought I would do a very short video up for you guys on bronchiolitis. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at a very important topic, bronchiolitis. If you haven't yet subscribed to the channel, please subscribe to the channel, hit the bell notification icon to be receiving notifications of such amazing content every time I post. Drop a like, drop a comment to show some support to the channel. So let's begin. I haven't been doing the warm-up questions in the previous lectures. I know some of you may have noticed, but I decided to add a warm-up question to this lecture. A 2-month-old baby boy is coughing, cyanosed, and is breathless with intercostal recessions. There is a history of slight rhinitis prior to the illness. Examination reveals some bronchi with a few crepitations. The most likely diagnosis is A. Asthma, B. Bronchiolitis, C. Croup, D. Cystic fibrosis, E. Tetralogy of Fallot. You may take your time, pause the video, and write down your answer. I will give you the answer at the end of the lecture. So when you talk about bronchiolitis, so these are two words that we have here. So bronchial and itis. So this is, in literal terms, inflammation of the bronchioles. So remember, this is a viral infection that affects the upper and the lower respiratory tract. And pretty much it will start off as a prodrome of this illness, such as this flu-like symptoms that eventually progress, so affecting the lower respiratory tract, the medium and the small airways. Remember that bronchiolitis is the most common respiratory tract infection, the lower respiratory tract infection in the first 2 years of life. Very common between the ages of 1 to 6 months. And the disorder is actually, or the disease actually is not so common in children that are above the age of 2 years. And as we've seen, the predilection is much more to the male child than it is to the female child, with a ratio of 2:1. There are some risk factors that are associated with bronchiolitis, so things like daycare attendance, multiple siblings. Remember, if you have older siblings or even just other children that tend to go out and play with other children, they may come home with these viral infections. Exposure to tobacco smoke, lack of breastfeeding. Remember that breast milk has some immune factors. It has some immunoglobulins. So breast milk has high quantities of secretory immunoglobulin A antibodies against the respiratory syncytial virus, which is the most common cause of bronchiolitis, and these are present in colostrum. And so children that actually are breastfed actually have a less chance of being hospitalized due to acute bronchiolitis. So you get more significant disease in patients that have chronic lung disease, in patients with congenital heart disease, meaning that those that you admit with congenital heart disease, make sure you cover them on some antibiotics. Those that have a history of prematurity, those that have immunodeficiency diseases, HIV being the most common cause of immunodeficiency in our setup, and then of course infants that are younger than the age of 3 months. What is the cause of bronchiolitis? Like I say, the most common cause is RSV, which is a respiratory syncytial virus. So this causes 80% of the cases. Remember that you actually have protection against RSV, which is mediated by antibody IgG class 3, the subclass 3. And of course, these antibodies have a shorter half-life and they don't cross the placenta in a substantial amount to actually offer the protection to the infant. That's why infants actually are predisposed to actually developing bronchiolitis. Other less common viruses include parainfluenza virus, influenza virus, adenovirus, human metapneumovirus, rhinoviruses, and even Mycoplasma pneumoniae, which is a rare bacterial cause. Then you may also have dual infection with respiratory syncytial virus and human metapneumovirus, which is associated with severe bronchiolitis. Now, what's happening in the pathophysiology? So remember, you have an airway that's present, and these airways are supposed to conduct air. And I want you to actually think of the physiology of respiration. Remember that respiration happens in 2 cycles. You have an inspiratory phase, which is an active process where you're going to be having air that is taken in to the lungs through muscles contracting, predominantly your diaphragm, and you may sometimes to some extent have the external intercostal muscles. Then in addition to this, you are also going to be having expiration, which happens passively at rest. So it means that the diaphragm will simply relax and the lungs will recoil. So keep this in mind, that inspiration is an active process, expiration is a passive process. And then also the airway size, the lumen, the radius of the lumen is inversely proportional to actually the resistance to the airflow. So it means if you have just a small change in the diameter or the radius of the lumen, this will then result in a significant airway resistance or impediment to flow of air. I want you to keep these things in mind. So remember that what is going to be happening is that initially this child is going to be having these flu-like symptoms. They may even have a coryzal illness that may be a prodrome to the condition. And then this is going to now lead to inflammation that's going to be caused by this viral infection in the bronchiolar mucosa. This is going to lead to edema. It's going to lead to thickening. It's going to lead to formation of a mucus plug and cellular debris. Remember that all these are accumulating inside the lumen of the airways. In addition to this, there's also going to be some bronchiolar spasms. So this is going to further reduce the lumen, the size of the lumen. And like I said, remember the airway resistance is inversely related to the fourth power of the radius. So this means that if you have any slight narrow change in the radius, this is going to cause marked increase in the airway resistance, both during inspiration and expiration. But remember that I told you that expiration is a passive process. So it means that the problem is going to be worse with expiration. So as this child now starts to expire, the airway actually partially collapses. Some of the air actually goes back, and in certain severe cases, the air may actually be trapped in the alveoli. So this may actually lead to emphysematous changes. When you actually look at the X-ray, you may see this hyperinflation of the lungs. Then you may also have some obstruction that may be completely the obstruction may be complete, and this may lead to airway trapping, and actually the air can be absorbed by the lungs and the lungs can collapse. So you may have atelectasis. So there is diminished ventilation, there is diminished diffusion. So this is actually going to be causing a ventilation to perfusion mismatch, and this may cause hypoxemia in the infants. So they may actually even present with cyanosis. Then, of course, there is retention of carbon dioxide that may lead to respiratory acidosis, and there may be the presence of eosinophils in the blood and respiratory secretions, and these are going to be suggesting that the viral infection that is initiating the wheeze attack in the child is already in a child who is already sensitized. Now, what are some of the clinical features that we're going to be seeing? So remember that the onset is going to be gradual. So there's going to be these upper respiratory tract symptoms, the rhinorrhea, the nasal congestion. You may have fever, which is often low grade. You may also even have a cough. So a few days following this upper respiratory tract infection, then the breathing becomes fast. This children go into respiratory distress. Remember, we're going to be seeing this by nasal flaring, use of accessory muscles, and then of course you may also have tachypnea. Then you may have intercostal and subcostal recessions. They may have a paroxysmal wheeze, which is common but may be absent. You may have a cough, you may have dyspnea that may be present. On auscultation, you may sometimes hear some fine crackles. Remember that if you hear bronchial breath sounds, if you hear very adventitious sounds, it's more likely that they have a superadded pneumonia and not really just a bronchiolitis. The spleen and the liver may appear falsely enlarged because of this hyperinflation of the lungs that tend to push the organs down into the abdomen. So there is also an increase in the anterior-posterior diameter of the chest, and the chest is going to be hyper-resonant to percussion because of hyperinflation. So these are changes that are quite similar to someone that actually has a COPD. Then of course you may have these apneic spells that may be present, and you should monitor them, especially in the young infants and children with a history of apnea of prematurity. Most of these infants are going to have mild symptoms and they recover within 3 to 7 days. Those that actually have severe disease are going to develop retraction of the lower intercostal spaces and the suprasternal notch by about 3 to 5 days. And in these severe infection, they may be dyspneic, they may also even appear cyanotic. Fever is moderately high. There is use of accessory muscles. Expiration is prolonged. Remember I said expiration is going to be affected more than inspiration. You may have crackles. You may have rhonchi, which are pretty much a wheeze that you hear with your stethoscope. And then the breath sounds may actually be faint or inaudible in severe cases. So don't think that the child has improved. In this case, they may actually have worsened. They may also have hypoxemia. So here's a picture to help you actually visualize what I've been talking about. So here we have a very sick child with bronchiolitis. So as you can see, apnea in infants less than 4 months. They have a sharp, dry cough. They may have cyanosis, it's appearing blue. They may have a dry cough. They may have pallor, they may have hyperinflation of the lungs. So the sternum becomes prominent, the liver is displaced downwards. As you can see, the liver is going to be palpable. You may have subcostal as well as intercostal recessions. Often they're going to be on O2 therapy. Then of course you may see fine end expiratory crackles, or rather hear them, and expiration is often prolonged. And of course there's an intravenous line to remind you that you must actually replace the fluids that this child is losing. If they're not able to breastfeed, you must replace these fluids. I did a good lecture on fluids and feed in the previous 2 videos. So if you haven't yet checked that out, you can check that out. So here's how the x-ray is going to be looking like. So when we're actually investigating the patients, remember that investigation of bronchiolitis is largely clinical. We're not going to be doing any tests that's going to help us make a diagnosis of bronchiolitis, because it's going to be mostly clinical. But if you do an x-ray, as you can see in this x-ray here, you have, although this x-ray is rather like rotated, you may see that there's hyperinflation of the lungs. So you may see changes that are very similar to emphysema. So in this x-ray, you have hyperinflation of the lungs. You may see air trapping. So as you can see, the lungs are appearing darker than they normally should be. You may see some patchy infiltrates. You may see focal atelectasis. The diaphragm may be pushed downwards, or it may be appearing flat. Then of course the lungs appear abnormally translucent, like they do here. They're appearing darker than usual. Then here is an x-ray of bronchiolitis with air trapping. As you can see here on the right apical side, you even have a pneumothorax where this arrow is pointing towards. This is air that's present in the pleural space. Then of course you may have some additional findings like bilateral parahilar infiltrates. You may also have atelectasis that you may see. As you can see, there are these non-specific infiltrates that we can see on this x-ray. Other investigations include a full blood count, so your leukocyte count may be normal or slightly elevated. You may also do some viral antigen or antibody tests. You may do PCR on nasopharyngeal aspirates. We were doing I think it's still currently going on. We are doing PCR for COVID, so we're not doing it for bronchiolitis. But in other places, they do PCR for bronchiolitis. It's the polymerase chain reaction. So like I said, diagnosis is mostly clinical, so it's going to be confirmed by your viral antigen or antibody test, which we don't do in our setting, PCR on nasopharyngeal aspirates, which we also don't do in our setting. But remember that bronchiolitis is generally self-limiting, so the symptoms are supposed to subside within about 3 to 7 days. Death actually happens in 1% of the severely ill patients. This is often due to respiratory failure. And of course, the relationship between acute bronchiolitis and bronchial asthma has been seen in about 25% of the cases. We should suspect that this may be asthma if you have a family history of asthma. If you have prior episodes like recurrency of these symptoms, then of course if they respond very well to bronchodilators. How do we manage a child that has bronchiolitis? Treatment is largely symptomatic, so we generally want to admit the child. Remember that the threshold for admission is very low, especially for the high-risk infants. So hospitalization is going to be indicated for the patients that have significant respiratory distress, patients that are hypoxemic, patients with apnea, patients that are dehydrated, and any patient that has an underlying cardiopulmonary disease. You want to position the patient in a certain position, so that's roughly about 30 to 40 degrees. The head should actually be elevated and the neck by 30 to 40 degrees. You give them oxygen. If it's mild disease, you can actually manage them at home in a humidified atmosphere, but of course if they are admitted, you actually want to give them oxygen. It's very important that you should prevent cyanosis, so you continuously give them moist oxygen. Make sure you keep the saturations above 92%. So with the very sick infants, you may actually need a concentration of 60% oxygen given through a hood that's going to be there. You may also, if the oxygen fails, you may actually continue giving this child the continuous positive airway pressure, which is the CPAP, or assisted ventilation, and this may actually be required to control respiratory failure. And then you may also use ECMO, which is extracorporeal membrane oxygenation, which has been effective if respiratory failure is not controlled by the mechanical ventilation. In addition to this, don't forget also to perform some nasal bulb suctioning, hydration for the child, and of course it's very important to carefully wash your hands before you attend to the patient and after you attend to the patient to prevent any spread of infections. Now you may ask, what about nebulization? Is there any role of nebulizing children with beta-2 adrenergic drugs? Is there any role of nebulizing children with ipratropium? Can we use drugs like albuterol? Can we use drugs like salbutamol? Well, this is actually controversial. So it may actually be effective in about 50% of the cases. So once you do this, it may work, it may not work. So remember that nebulization is not recommended for infants less than 6 months because generally even the receptors that are present that are supposed to respond to these drugs are not yet fully developed in this infant, so even the response is not as good. And a recent study actually showed that there is some beneficial effect of inhaled salbutamol with ipratropium and epinephrine, but still there is some extensive studies that are going on in this. But if a patient actually shows improvement, you may continue on the bronchodilators. So you may or may not use them. And if you decide to continue using them, you can actually nebulize them for 4 to 6 hourly. What we actually do use the nebulizer for in bronchiolitis, we actually use it with hypertonic saline to actually clear out the airways. But in the cases of where you don't have hypertonic saline, you may actually use normal saline. Then, of course, you do not forget to have fluid and electrolyte balance that should be maintained in these children. Steroids. Do they have any role? So remember that steroids are rather controversial and may be most effective in patients that have a prior history of wheezing, though we don't really use them in bronchiolitis. Nebulized racemic epinephrine may be effective in reducing airway constriction, but we also don't routinely use it. Aerosolized ribavirin actually is a drug, an antiviral that works against RSV, which may be considered in some very ill infants. We don't have it in our setting, but of course the evidence of definitive benefit is actually lacking from all the children that have actually received the ribavirin. Antibiotics generally have no role. They may actually shorten the course of the illness in infants with underlying congenital heart disease, those with chronic liver disease, and even immunodeficiency. But if it's purely just bronchiolitis, there is no role of antibiotics unless if there is a superadded bacterial infection or if they're at a high risk of developing a superadded bacterial infection. We may actually give RSV monoclonal antibodies, palivizumab, which is actually maybe given prophylactically by monthly intramuscular injections during the RSV season, and these may actually prevent severe disease in the infants, especially infants with a history of prematurity, those with chronic lung disease, those with cyanotic or hemodynamically significant congenital heart disease. What's the differential diagnosis you should keep in mind? So it could be bacterial pneumonia. So what are the things that are going to be leading you towards bacterial pneumonia? Remember that the fever is quite high, number one. Number two, the signs of obstruction in pneumonia is less prominent. But if you actually listen to the lungs, you get these adventitious sounds in the lungs. You may get this bronchial breathing in the lungs, and the crepitations will be much more pronounced. Then, of course, if it's a foreign body in the trachea, it's going to be diagnosed by the history of aspiration of a foreign body. There may be a localized wheeze and, of course, signs of collapse or localized obstructive emphysema. If it's bronchial asthma, remember that bronchiolitis is often confused with bronchial asthma. And remember that bronchial asthma is unusual below the age of 1 year. And of course, there should be a positive history of asthma in the family. Then with congestive heart failure, you may see some features on the x-ray like cardiomegaly. There may be other features on examination like tachycardia, a large tender liver, raised jugular venous pulse or pressure. You may also have edema, and of course you may have some crepitations on when you auscultate the lungs. Just to end this lecture, what are some of the complications that we may see with bronchiolitis? So like I say, there may be a superadded bacterial infection, which may warrant the use of antibiotics. You may have bacteremia, you may have dehydration, respiratory failure, pericarditis, cellulitis, emphysema, meningitis, and even suppurative arthritis. Coming back to our single best answer. A 2-month-old baby boy is coughing, cyanosed, and breathless with intercostal recessions. There is a history of slight rhinitis prior to the illness. Examination reveals some rhonchi with a few crepitations. The most likely diagnosis is. So if we look at this question, this child is coughing, they are cyanosed, they are breathless with intercostal recessions, so they have something respiratory going on. With tetralogy of Fallot, they may give you a history of cyanosis, yes. They may give you a history of difficulty feeding, and of course they may give you a history of this child having these TED spells. You don't have a history of rhinitis in tetralogy of Fallot. With cystic fibrosis, these often are just associated with malabsorptive syndromes. They're often associated with recurrent pneumonias, recurrent lung infections. Then of course with croup, you may have this characteristic barking cough. Asthma, like I said, is very uncommon in a child that's 2 months old. So leaving the only answer that's correct as bronchiolitis. I really hope you enjoyed this lecture on bronchiolitis. If you did, drop a comment, drop a like, and subscribe to the channel. It really helps the growth of the channel. I'll see you in the next video. Until next time, my name is Dr. Moses Kazevu, to Zambia and beyond. Bye bye.